people needed to be in the OR by 7:30, quarter to 8. We met at 6 o'clock, 6:10 in the morning, and by 6:15 sharp, we were starting our mocks. At this point, I'll hand it over to Jonas.
Thanks, Shelley. I'll provide just a high-level overview of the methodology that was used to evaluate these operating rooms, and it was a really interesting collaboration between Vancouver Coastal Health, the Health Quality Council of Alberta, where I work, in the W21C Award of the 21st Century. And the methodology that was used to evaluate those mock-ups is fully described in the simulation-based mock-up evaluation framework. This is a framework that I led the development of with a number of other individuals and organizations. And it's available for free on our website. The link is here, and I think Kat will also post it on the chat forum. By way of background, that document is included in Canada's National Design Standards and Guidelines, so that's CSA Z8000. It's also in our provincial standards and guidelines in Alberta, and it's also listed on the FGI website in the US as one of their resource documents. But the process, sort of at a high level, is to, I guess, build and then evaluate a mock-up. So this is some pictures of the mock-up that we evaluated. So it was located in the basement of the Vancouver General Hospital. And then within that mock-up, it was furnished with as much real equipment and real surgical supplies as possible. Where real equipment and supplies weren't possible, they were mocked up as well using 3D printing and other techniques to allow people to enact simulation scenarios as realistically as possible within this mock-up environment. So a number of scenarios were done. Shelley mentioned there were 18 different scenarios that were enacted. The human factors team was involved in 5 scenarios. 3 of them were at the very beginning of that process that we can see here. So that was in October 2017. And then we're also involved in the very last 2 of those mock-ups in January 2018. One of those scenarios was repeated. That allowed us to test some of the design changes because changes were made after every 3 mocks. So we were able to see what impact some of those changes had on the workflows, processes that could affect quality and safety. In terms of the results and the findings, we, through video analysis, coded a number of behaviors that were observed. One of those was bumps and congestions within those mock-ups as part of the scenarios. And what we saw was a pattern that looked like this. So this is the location of where all of those bumps and observed congestion points were. We see there was a clustering in the red box there. And most of the congestion in that space involved trying to squish through the surgical prep area because as we can see, the door to the left of that goes to the sterile core. So as people entered from that sterile core, they needed to navigate through that surgical prep area. And so one of the recommendations was to move that door and a pass-through further towards the head wall to make it so that they weren't entering and needing to go right through that surgical prep space. When we retested this in the final mock-ups, what we saw was it dramatically reduced the amount of congestion in that space, so a 58% reduction in the amount of congestion involving those surgical prep tables. Another thing that we were really interested in was the location of booms. So the green box, the auxiliary boom in the anesthesia area, is connected to the blue box, which is the anesthetic machine. And the red circle shows the full range of motion of where that auxiliary boom can move. And what we learned through the debriefing was that in some cases, the anesthesia team needs to push their anesthetic machine out of the way to create space, for example, in a resuscitation case. So we looked at the placement of the boom in the anesthesia machine over scenarios, saw a pattern like this, and noted that the auxiliary boom was generally always being placed at its edge of its limits, which meant that the anesthesia team couldn't push that equipment out of the way when they needed to. So a recommendation was made to move that mount location towards what we see on our left so that it wasn't at its full extent. And then when we reran the scenarios, we saw that it allowed for more room, I guess, to move that anesthetic machine out of the way. And again, we saw a decrease in the amount of congestion and bumps in the anesthesia area before and after from the initial mock-up to the final mock-up. So these are a few of the changes. And overall, what we saw was that the design changes resulted in better room utilization, so more of the room is being used as measured through link analyses or spaghetti mapping. We saw that there are fewer constraints with equipment mobility, so people could place those booms where they needed to be placed after the design changes were incorporated. There was less congestion. We saw that in both of the examples I provided today with the movement of the door and the movement of the auxiliary boom placement. There is also very positive debriefing feedback, both from the clinicians who enacted the scenarios, but as well as from the observation group, who was mostly comprised of the design team members and different stakeholders. Lots of positive debriefing feedback. And with that, I will turn it back over to Shelley.
Thank you, Jonas. So what you see in front of you right now is a picture of our first OR, affectionately known as OR 25. This is the result of our design efforts. What you see in front of you is the blue doors, or the two main doors in. Immediately to the left of that is the physician workstation. As we move around, we move into the anesthesia space in the room. And then as you come, you can see the boom, finally the boom. And then in the infield, looking at this picture, you can also see to the right of the blue doors would be where the nursing station is going to be. We have 3 booms, 4 lights, infield lights, and we have also a video power monitor that's going to be in the corner by the physician workstation. This is a picture of the wall, the core wall. This is the single door into the core. As Jonas alluded to, one of the first findings from our mocks was we needed to move that door closer to the head wall, and that's what you see here. The pass-through is immediately beside it. And then to the very right, you'll see a 2-shelf shelving unit. That is the nursing shelving unit. And one of the things we found when we were able to go into OR 25, the first week in January, our construction team turned it over to the program. We could go up and have a look, just make sure everything was where we needed it to be. And one of the things we discovered at that point was this shelf just wouldn't work. So what we did was we went away and we've designed a complete different shelf that is going in there. And we just saw the final result late last week, and it's a beautiful shelf. Our nursing teams are more than satisfied with it, and it's truly going to meet our needs into the future. So the results and the findings from our design through to the mocks that Jonas and his team led us through, and then through to final design, is what we found after we were in OR 25 to have our final look. Very few changes needed to be made. We were really, as a project team and as a construction team and just everyone who's worked on this project to date, we were all very happy with the way things turned out. We had to make a few minor changes. One was our anesthesia teams, the boom arm wasn't long enough for the anesthesia boom, so what we've done is we've extended the boom arm, so we're going to go with the longer boom arm. We did have to relocate a few power and data outlets as we did our final review of the room, again keeping in mind as either equipment had to come in or where shelves were. We didn't want people bending down and you know, having to navigate other structures. So we moved a few power and data outlets to make ease of access. As I said, we redesigned the nursing shelf. Even simple things, we had our facilities folks come through, and one of the things they noticed was our temperature, our room temperature monitor for the room was located by the front door, which really, you know, when we sat back and looked at that, did not make sense, because as there is traffic coming in and out through the main doors, and while we want to minimize that clearly, there is still traffic. There was the tendency to affect the temperature of the room. And then also, as we brought in additional pieces of equipment such as O-arms and the heater cooler units, they throw off a lot of heat that would have mistakenly drove up the temperature, because the temperature monitor. So we moved that to a different place in the room where it's really, you know, it's not going to be impacted by some of those scenarios. And lastly, the one thing I would leave with folks is really our staff, when they came up into OR 25 and they saw what we designed and they saw how it came together, our staff really owned the room. I think people who came up could see where their fingerprints were on design. They could see where they were part of conversations. And really, you know, it was really gratifying for me personally as the project director to really see that people were happy with what the outcome was. And really what we were able to do after looking at OR 25 is we gave direction to our construction company to build out the rest of the team, so that when the other 15 are built out, we don't have all of these same mistakes and have to go back into each 15. So we are confident that what we built out in OR 25 will work for the remaining 15, and we are looking forward to opening up our surgical suite in January of 2021. Thank you.
Thank you, Jonas and Shelley. And now it's your turn to ask questions of the authors. So please feel free to type in any questions you may have, and we will try to answer them. But before we get started, Shelley and Jonas, I was wondering if you could first just kind of share with us how this relationship developed between your two teams.
Certainly, I'll take a stab at that. So one of the things we've done from the start of this project and really carried it through right through to what you saw in OR 25 is, first and foremost, this has been a clinically driven project. So at the end of the day, from our CEO and our vice president, it was made very clear that this needed to be a space that our surgical perioperative staff would feel proud to come and work in, number one. And number two, it would be a space that they could work most efficiently and effectively in. So what we did as a project team is I have a project team that's comprised of upwards of 30 people. And what it is we have representation from everyone who works in the OR, from the surgeon to the surgeon assistants, to anesthesia, to nursing, to AAs, PAs. Everyone who has a hand in the OR was asked to participate in the mocks. Then what we did as a project team is we really looked to see where we could leverage expertise to help us in design. Because what we found in the early days of our project is every provider knew their piece of the design puzzle, but they didn't really understand how the rest of the team and what their design requirements were could really make the room a more efficient room. So at that point, what we did was we reached out to Jonas and his team, because they are known for their expertise for human factors design, and we brought them in to help us. And as you saw through the mock scenarios that Jonas walked us through and that they helped us with, we really were able to see things that as individuals sort of in the weeds every day you can't see, but when you bring in another area of expertise like Jonas and his team, who come at it from a completely different perspective, really holistic, objective, they brought something to our table that we wouldn't, I think, have recognized. The other thing that I would just add before I turn it over to Jonas is Jonas brought expertise that none of us questioned. I think had we tried to do some of that internally, you know, that isn't our wheelhouse, that isn't our space. So again, the one thing, you know, Jonas brought just a great amount of you know, value to our project. But I think at the end of the day, the other thing he did was really bring his expertise, and it was quite interesting to me how our clinical team really grabbed onto that. You know, we had good conversation. I think we had challenging conversation back and forth with Jonas and his team when they were in the room. But really, at the end of the day, they were the experts, and we really relied on their expertise to guide us. Over to you, Jonas.
Thanks. Yeah, thanks for the kind words, Shelley. Yeah, so I guess from my perspective, Shelley and some of her colleagues had reached out, and I think it started with sort of a brainstorming session of what it could look like. They had mentioned that they wanted to do these mock-up evaluations, and that led to, I guess, us flying out to Vancouver and having sort of a scoping meeting where I presented an overview of what the project would look like, received some feedback from that clinical design team, and then we started just scoping out how that project would work. And so it was a really neat collaboration where they do have some human factors expertise in Vancouver. So they were involved in the team, and they were fully participating in that. And then we also had expertise. And so I suppose I led sort of a leadership role in terms of scoping out that evaluation and pushing it forward. But it was truly a huge group effort by all of the different stakeholders that were involved. Yeah, absolutely.
That's excellent. That's excellent. So we've got a couple of nuts and bolts questions for you all. So first of all, how was the room size determined to begin with?
Right. The room size was determined based on our existing footprint. So as we said earlier, we were building on an existing floor in an existing facility. So we were really limited in what we could do. If it was a green field and you can build whatever you want, it might have turned out differently. But we were limited by our footprint. So what could we do? We knew from the modeling that we had done, the clinical modeling, that we needed to get as many ORs up there as we could. And based on the fact that we needed to build out operating rooms, pre and post recovery bays, of which we built 40, all the supporting spaces that go into a perioperative suite, like slating offices, control desk, everything else that went in. That is the design that we landed on within the footprint that we had. The other key foundation that really guided all our work, and I have to say it was a bit rocky at the beginning, just having people understand and really on board, is the universal OR. So really one of the things we felt very strongly of in this design is we absolutely had to build rooms that any service could work in. Right now within our current suite, we have different sizes, different shapes, and every day our control desk is doing gymnastics, just trying to figure out where the next case goes, because they can only work in certain rooms and certain sizes and certain equipment. So it was really important for us that we came up with a design that any service could go into any room and they could work efficiently and successfully. Now, what we're going to do when we operationalize, obviously, is we will cohort services to certain rooms, meaning that's when you're on the third floor, that's where you're going to work. And that was mostly because so that we could build out our sterile core to support them accordingly. You know, we didn't want them to be in one pod and then another pod and having to move equipment through the sterile core. So that really guided our size and our shape, and really, again, universality was a non-negotiable. That was a real that was something we really had to sell with our teams, but it was non-negotiable. And really, you know, in the early days, there were services that asked what room was going to be theirs, and it was like, well, no room is actually going to be theirs. But what we did was we worked with all the services to make sure the rooms would work for them and what equipment they would need and could it move in. The other thing this project has enabled us to do is really look towards standardization. So rather than have every service have their own microscope or have their own X, Y, and Z, how can we standardize some of that equipment and really leverage our buying opportunities to buy more with less money, because you're buying more of the same instead of, you know, these one-off products to suit certain services. And, you know, I have to say our 2 surgical leads and 2 anesthesia leads have been instrumental in carrying that conversation with the rest of their peers.
That's fantastic. So going off of that universal theme, there are a couple of questions regarding, did you scenario test the incorporation of robotic equipment in the simulations? Did you look at that? And then did you look at a mobile nurse charting desk as well in part of that universal?
Thank you, Deborah. So mobile nurse charting, yes, there is going to be mobile nurse charting. What we've done is we've created, we didn't show it in the picture, but in the corner where the nurse desk is, there's going to be a fixed shelf, but then what we have is mobile desks that will move out into the, closer to the field so the nurse can chart that way. So yes, mobile nurse charting. In regards to robotics, robotics is on our 2nd floor right now, and we are planning to do a phase 2 renovation where we go down to the 2nd floor and renovate those spaces. And the idea would keep the robot down on the 2nd floor. So we didn't do a whole lot of work around simulation with the robot. But, you know, we did have some preliminary conversation, and we did talk with our robotic services to say, what would this look like? And we just brought them into the space and had a conversation where would things fit, but we didn't do a full-on simulation. The idea is we would do that in phase 2, keep them on the floor.
I think add to that, I think, is the nursing station was one area where we received a tremendous amount of feedback, and it was one of the things that was quite iteratively tested. So it started with kind of an unknown as what it would look like, and then it got kind of changed to a different shape and a different spot, and it went through a lot of iterations, and so it kind of landed on, I think, a series of sort of design guidelines, I suppose, for nursing stations without a final solution. And so now they've come up with that after the mock-ups, I suppose, the final solution. Yeah.
And I would just add one more thing as well. I think our nursing colleagues who are on this webinar would be happy to know that, you know, our nursing staff really landed up with a nursing desk that works for them. So often, you know, what we heard out of the gate is, you know what, you just can't put us in a corner and say, be happy with a little desk. So to Jonas's point, we spent a lot of time on the design for them. It seemed like a simple thing, but again, it's really important. They're really, at the end of the day, the one thing we learned as a project team is really the nurses are running the rooms. Let's be clear. They set them up. They know what's going on. They know what everyone needs. So, you know, it was really important that that their needs around a nursing desk were met as well.
Absolutely, absolutely. And another question regarding this would be, did you use modular walls at all for your construction?
We did not use modular walls. We did not.
Were they considered at all during the mock-ups in any form, or?
They were not. They were not considered. That was, no, they were not considered.
Okay, great. Let's see, we've got tons of questions here, so let me see. Were there any conflicts between the boom placement and the curtain wall with the HVAC?
Mm-hmm. Jonas, do you want to start on that, and then I can?
Yeah, so a couple of, were there conflicts? So in some cases, yeah, we were trying to test out where that curtain wall would be and where the booms would be. We focused more on where the booms needed to be and making sure that they could get to for example, the full side of the patient's bed. There were instances where the surgical table didn't get centered properly when it got moved. And so some of the things that we learned was centering that surgical table back in the right spot so it would stay within were some of the recommendations. There were some recommendations to create visual cues of where that surgical sterile curtain is located and a spot to know where the bed is centered so that it gets placed in that same spot. I think those were some of the ideas that came out of those types of things.
Right, and I would just add to Jonas's comments, really, we started with the table in the center of the room. Again, through some of the mocks we tried some different scenarios where the table was either pushed, you know, more towards the foot or more towards the head. And we always found it landed up in the center of the room anyways. So you push it back, you push it forward, and at the end of the mock, it was still in the center of the room. So what we did was we centered the table in the room with the understanding that it could move anywhere within the confines of the laminar flow and the curtain. And then what we did was we designed the mocks around that accordingly, or the booms, excuse me, around that accordingly.
Excellent. So one of our questions is, what was the most challenging aspects of the mock-up process?
Sure, I can speak about, I guess, in general terms of many mock-ups that I've been involved in. One of probably the biggest challenge, I suppose, is just getting the proper amount of time and budget carved into the design process. And that was one of the really big successful pieces of this project, is it was planned for very early in the planning process. Oftentimes what happens is design teams become aware of these simulation-based mock-up evaluations partway through the design process, and then all of a sudden need to try to carve out more time and resources to allow this process to be embedded within their project. So that's kind of one of the challenges. It wasn't necessarily a challenge in this project, but is a common challenge. The next is recruiting participants, and Shelley mentioned this on one of our first slides, but it's essential that the people who participate in the scenarios are the planned end users of the space, who are not part of the project design team, because they bring a different perspective. And so getting all those people to participate is the challenge. And some of the things that we did to try to minimize that challenge was having the simulation scenario split into two parts. So there was part A, which was all of the room setup. And then part B was the actual surgical procedure, which then required the surgeon and the anesthesiologist. We did that to minimize the time requirements for the surgeons and anesthesiologists, but we also were able to put them in different parts of the day, knowing that they really are only available early in the morning. We ran those mocks at, I think, 6 a.m. or something like that, so that those individuals could participate. And even still, there were challenges around that. Sometimes they would get called in to work in the OR and provide real patient care, and so that would trump our mock-up evaluation process. So it still presented challenges that we had to work through. And then the other is, what was neat about this was the collaboration. And so having people involved in the data analysis process who were not physically located created challenges. So we had people analyzing data in Vancouver and in Calgary at 2 different sites. And so being able to create a process that they could do all of that, but then still resolve data discrepancies to kind of come to a final data set was a challenge, but it just took team meetings, I guess, to make sure we were all on the same page in what the process was, how we were going to merge data and resolve discrepancies. So that was a challenge, but yeah, we definitely worked through it. Yeah. Shelley?
Yeah, thank you, Jonas. Just to add a few more comments, as Jonas indicated, I think for us as a project, we were very clear from the start that the scenarios were going to drive design. So we didn't get into any kind of detailed design until we landed on completion of these mocks and what our findings were. And it really drove design instead of we're designed and oh my gosh, I think we got it wrong, let's try and fix it. So we were very deliberate in our planning in this whole project so that it was done at the right time and really we could keep building incrementally on the next steps. As Jonas indicated, it was a challenge getting people out at 6 o'clock in the morning, but I have to say from a surgical perspective, people came out, we had surgeons, we had fellows, we had residents, we had, nursing students, we had everyone come out and really participate. So it was really a great, experience for them as well. And again, I think it was important for people, all of our staff, to know that they had a say. We just didn't bring them down and then go away. Like, we followed up with the debrief. We followed up with our findings. We followed up with, these are the things that are, we think we want to decide upon versus these are the things we weren't. And then, the one thing we learned really early on was you can't react after every mock because you get lost. And we talked about that last time and we changed. And now in our second mock, we're back to where we were. So very early, I think it was our second mock where we said, okay, we need to stop. And we're going to revisit all our findings after every third mock, and we will design as a team. So for example, moving the core wall up towards the head, that was an issue for the first 2 mocks. So we just moved it. That was something that needed to be done. And it made an impact, obviously, in design. So we just kept trying to leverage findings from every mock. And we really did not go back and summer follow over items that we had already talked about and addressed. Like, unless there was an exception that we really think we missed something, we would bring it forward for discussion. But we really kept the whole process moving forward. And then the last comment I would make is, the work that went into the scenarios, we actually mapped out, my clinical project manager mapped out the simulation. So we used a real staff person as a patient was on the bed, got wheeled into the room by anesthesia. And so we got the patient perspective as well. So when they're laying on the bed and they've got all these people working over them, we were very mindful about what that looked like. So again, it gave us some insight from a patient perspective. And then we checked things like if you needed to bring diagnostic imaging in with a portable x-ray, what did that look like? Where would they come in? Where would they position? How would they work around other equipment that might have been in the room already? We ran a code blue. So now we're in the middle of the field, everyone's at the field working on the patient, and now they've coded. So what do you move out of the way to move into the way? So we really, our team was very type A. So we were, let's just cover every possible scenario. So it was a really great experience that way as well.
That's excellent. Excellent. So speaking of that, how many hours went into the evaluations? And then kind of the second part to that is, what were the costs and benefits associated with respect to the changes that you were able to incorporate into the design? Do you have any idea on the value of that?
Jonas, would you like to start with that question?
Yeah, hours, I don't know. I know for myself, the number of hours, so the mock-ups, I had 142 hours that went into the project in total for me. I don't know what the total was for the other people who were involved in the project, so I can't really speak at sort of a macro level. Yeah, but you might know more, Shelley.
Right. So the way we structured, we continue to structure our project team is our project team met every Monday. Monday became OR day. So everyone, our surgeons, our anesthesiologists, everyone who was part of our project team, everyone cleared their calendar on Mondays, and we scheduled as many meetings as we could on Mondays to get everyone to come. So as you can appreciate, you know, surgeons and anesthesiologists and, well, basically all the clinical staff, they're working when they're not in meetings. So it was really helpful to, number one, secure 2 surgeons and 2 anesthesiologists where this was their work. They were our project leads. So we scheduled meetings on Mondays so they could come. As far as following up after every mock, what we would do is we would have the mock from, you know, 6:10, 6:15. It would end around 6:40, 7:45. Then what we would do is we would stay back, and as a team we would debrief probably for 30 to 45 minutes, and then we would go away and we would have folks on the team summarize the conversation. We would send it out for everyone for review. So, you know, we just kept it iterative, and we kept the documentation thread going so people could see what was looked at, what was discussed, what the challenges were. And then what we also did in the room, knowing that we changed after every 3rd mock, after every debrief, we would put on a whiteboard, this was an issue that came out, let's keep it in mind. And then when we came to the end of every 3rd mock, we would go back to that whiteboard and say, okay, these were the issues that were our big issues over these past 3. What do we want to make a decision on, make a change for the next 3 mocks? So we tried to be as nimble as we could in keeping track of all the information. As you can imagine, there was just reams and reams of information, and really deciding what do you take note of versus what is just conversational. You know, I think we really found our cadence in that as well after, you know, the first 3 mocks, figuring out what we needed to keep track of versus what we didn't. So for my team, again, every Monday for, you know, basically the last 2 years has been OR day, and then we would have meetings, you know, sporadic meetings throughout the week as necessary as well. So, you know, lots of hours. I can't quantify what the hours are, but from a cost benefit perspective, to get to that question, there's no doubt in my mind that the cost, and it's a small cost in the scheme of things to both have Jonas and his team come out and help us with a handful of the mocks, but even just for our team to go through it, it really helped people think through what's required in a room. And I think as we talked at the start, it really gave insight into every provider, into what everyone else in the room needs when they are coming into the room to work. So it's not just about thinking about your own space in the OR, but how does where you work affect someone else in the room, and really how the flows work. So, you know, I just think, you know, it's unquantifiable what the actual benefit was, because when I look at OR 25 and how we went in and had a look in January to see how did we do from a design to a build, we nailed it. There was a few things that we changed, but honestly, I can confidently say we nailed it. But, you know, we should have nailed it because we spent so much time with stakeholder engagement. It was so important, but you know, the result is they are going to have a space that they are going to feel really good working in. And, you know, in OR 25, when we brought people through, we had, you know, we had happy surgeons, we had happy anesthesiologists, our nursing staff were thrilled. Like everyone just really, as I said, they own the room. They can see where their fingerprints are, and they are happy with where we landed.
The other thing I'll build on that is one thing that was really, I suppose, unique, but also really successful with this was the iterative nature of the mock-up evaluations. I've been involved in quite a few different mock-up evaluations, and this is the one that had the most iterations out of anyone that I've ever been involved in. So with the 18 different simulation scenarios and all of those iterative changes, and then retesting it and revising it. That was really unique, and I think that's what really made them land in a really good spot. Most of the projects that I'm involved in, you have one opportunity to do one mock-up evaluation based on one design, and that's still amazing, and it's still really helpful, but it's not as iterative, so there's less opportunities to improve. In a couple cases, I've done a couple of projects where there's been 2 iterations, but never this many. The only exceptions would be in research context, where I've worked with Deborah and other folks at Clemson University and Angeli and David Allison, where it's been in a research context. So you have more generous, I suppose, timelines that can allow you to be really iterative. And so I've done it in that way through academic settings, but this is the only time I've had that opportunity to be as iterative in a real design project. So yeah, I think that's one thing to add that's important.
And I'll just add one more comment there as well. The reason we did so many mocks, if we go back to our concept of universality, we had to make sure that this universal room would work for all our services. So, you know, and what we found through the mocks is we found certain services like our multi-service teams, ENT, Neuro, the table would have to shift and take a different position in order for everything to come in. You know, for our DEP procedures, we have 2 teams working at the same time. We need to bring the microscope in at a certain time. So we really had to make sure that if we were going to, you know, live and die on the universal OR sword, we had to run everyone through. So that was another reason that we did all these mocks, because every mock was a different service. The services that Jonas walked us through, the reason we did them again was to do the before and after, but every mock was a different service, and we basically covered all our services in the 18 mocks. So that's another reason why we did so many and why it was so iterative.
That's exceptional, truly exceptional. We did have a question though. How many of your staff who participated in the mock-ups are still there?
Well, you know, that's really interesting too. One of the things, we just had a conversation on this last week. One of the reasons I believe our project has had the success we've had to date is we've had very little turnover. I'm just trying to think of anyone who's left the team, and everyone has stayed on. So that, I mean, obviously that's a great question, because there was no knowledge lost along the way. The people who started this project are still here. So, and everyone was so invested. So we've had no attrition, actually. I'm just trying to think. No one from our project team has left. And even the staff that participated in the mocks, the surgeons are all still here. When I look at the nursing staff that came down, they're here. One of the other things we did in our design is we were very mindful that, you know, who is the younger generation working in the OR that is going to live in this room for the next 25, 30 years. And some of our senior surgeons and some of our senior nurses were very insightful. And that's really what they said. You know what? I am not actually going to work in this room, so maybe we should be talking to the younger generation from my service or from my team, and they should really inform. So even that was a really great, I thought, you know, insightful approach. And not that they've been hands off, because some of the older generation are still here, obviously, when we work, but they've really felt strongly that, you know, the next generation really has to design it, because they're going to be the ones working in it, not me, who's end of career or close to end of career. You know, really forward thinking that way. So we really, that's how we also tried to focus staff who were participating, find a mix, but really, you know, with the younger generation, if you will.
That's amazing. That is fantastic. We've got several questions here that are kind of nuts and bolts regarding methodology. So I think it'd be really great if you could, you touched on it a little bit, but you talked about this mass of data. So could you talk a little bit about, first of all, just the data management and how the analysis and the synthesis, and a little bit of what that took? I know that's a much larger conversation, but at least some of the nuts and bolts, I think our listeners would really like to understand a little bit more how that took shape.
Yeah. Sure. So kind of, I'll take a bit of a macro level response, I suppose, to this, but in short, it's watching videos. We videotaped everything from 4 camera angles, analyzed data for very specific behaviors that were identified to answer research questions that we were interested in, and then resolved discrepancies between the coders to say we had a final data set in terms of that identified all of those behaviors. And how we go from the beginning to the end of that process, there's a lot of different options. So there are kind of low tech, medium tech, and high tech options. I would put this in the medium tech category. The low tech, we've done this before by coding behaviors in an Excel spreadsheet and aggregating Excel spreadsheets. So that's the low tech, that's where we started. It can work. In this case, we used a software platform called Noldus that allows you to code behaviors, and it helps to merge data together, and it timestamps data very well and does things like that, that you can kind of come up with a final data set for bumps or anything like that. And so that's what was done here. And so we had coders in the different areas coding through Noldus, and then it would merge it, and then we'd resolve discrepancies. And then the high-tech one, which we didn't use, but I have experimented in other projects that we're not talking about today, but is through virtual reality software. We've done simulation scenario enactments within virtual reality. And we were able to, through a company in California called Sim Insights, they were able to automate the entire data analysis process when done in virtual reality. So it can identify all of those bumps and congestions and do that work for you. It takes a lot of setup work, but it's a technology that we'll probably see in the future as that technology evolves and advances. The link analysis was done by, actually, that was kind of a low-tech approach where we just used PowerPoint and drew out where people were moving in the scenario enactments onto an architectural drawing, and then just overlaying, for example, all of the different nurses overlaying to get nursing workflow, and then adding anesthesia to show their workflows. So there's lots of different options and different ways of doing it. And in our case, we were using Noldus for this project.
And to what degree then did you layer in the qualitative commentary and all of that as well?
Couple different ways. So one of the things that the qualitative, because there was debriefing sessions that occurred after every one of the scenarios, two different debriefing sessions occurred, one with the participants, and then we would overlay it with all of the observers and gather their feedback separately and put them together. So one way we use it is to further identify how we want to analyze the data. So that, for example, the boom placement was one of the things that came up during the debriefing sessions. We said, okay, this is an important thing, so let's analyze that. That wasn't part of the initial plan. And so we plotted out where all of the booms were placed across all of the scenarios. But the other way is it provides, good feedback as well as design ideas in terms of here are some of the challenges, as well as here are some other design solutions to consider. And then we'll look to the data to see if they validate some of those ideas that were put forward and see if there's any ways we can put evidence to some of the suggestions. And sometimes we can't put data to it, but instead we can just pitch it back to the design team of, well, here's some idea. We don't know if the data supports it or doesn't, but it's still an idea to consider. So yeah, there's a couple ways that we pull in that qualitative data from all of the debriefing sessions.
Excellent, excellent. So as we're kind of wrapping up here, it would be really great if you could talk a little bit about how did you manage, kind of this hierarchy and that usually exists in healthcare, and how did you help to really get it to this, a shared decision-making process amongst everyone? Could you kind of share some tips or tricks about that?
Sure. Well, a great question. What we did from the start of the project is we really, set the stage. When we invited folks to join the project team, they were bringing their area of expertise, absolutely. But what we did from the beginning was this was going to be a collaborative effort. Everyone was going to bring something to the table. But we were going to flatten the hierarchy in the sense that, traditionally in the surgical world, the surgeons runs everything and everyone just falls in line very respectfully. Yes, they do. But one of the things we found really early on, and the surgeons actually identified it themselves, is it's actually the nurses that run the rooms. Let's be clear, right? So it's really the nursing staff that know, what every surgeon wants, how they like to be set up. They they see the big picture. And then what we found through the project, really coming together as a team, meeting every week, going through, the simulations and everything else we had to go through, people started learning about each other and what their roles were and how, what your need is and what my need is. And I can give you an example. So early in design, we landed on a boom structure design. We had designed our rooms, we had the booms all laid out, and our vendor said, you know what, we have an issue with the booms that you're ordering, we can't deliver them. So what we had to do was we had to go back into the room and we had to say, okay, what does that mean? Because we had designed the whole room on this boom technology that was no longer going to be available. So, you know, what we had to do, we were well into detailed design, we were well into contract drawings, ready to sign things off and hand it over to construction. So what we had to do as a team, we had a 6-week window where we had to come together, we had to go back into the rooms, we had to figure out what did this mean from a boom perspective, were they still in the same place, what did we have to change? We landed on the equipment boom, we landed on the anesthesia boom, but there was an issue around the auxiliary boom that was going to be brought in as our third boom if we needed it, and where were we going to put it? And everyone had an opinion, and they were divergent opinions. So what we did was, you know, there was a lot of swirling for a couple of weeks and people became entrenched in their opinion. So what I did was I pulled together all the providers that work in the room, basically said, okay, this is an opportunity where each one of you are going to have 3 to 4 minutes and you are going to tell us why, from your perspective, you feel one way or the other about this boom and why we need it or why we don't. And I said, what we're going to do is no one can interrupt. Everyone's going to have their 3 or 4 minutes. You're going to almost state your case. And then what we'll do is we'll have conversation and we will we'll land on a decision that way. But let's just all, you know, let's be forthcoming. Let's put all the elephants on the table. Just put everything out there, because we were all making up our own stories about what people were thinking and why they wanted things. And, you know, it was really interesting. I went and I met with every group ahead of time and I said, you know what, this is what I expect you to do. We're going to create a safe environment. You know, it will be a confidential in-camera conversation, but we need to land. And they were all, yeah, we'll come, we'll be ready. So we come to the meeting. We started out, nursing started out, the nursing teams, and they said, you know what, we want that auxiliary boom. And the reason why is ABCD, they came up with their whole argument as to why it was needed. And they said, you know what, we'll even park it in our corner of the nursing station, corner of the room. They thought it through, they presented their case, and that's how they felt. Next up was anesthesia. And one of our anesthesia leads was like, you know what, he said, I actually talked about this boom with my department. And he said, I came into this meeting, you know, I was going to be very adamant that that boom had to go. We didn't need it. Nope. And he said, you know, he said, after listening to my nursing colleagues, he said, why do I care that the boom's in the room? I don't use it. So why would I care whether it's in the room or not? You know, you as the nursing colleagues use it. So if you think you need it, I'm going to support you. Surgeons were the next ones up and they said the same thing. You know what? Yeah. Why would we care whether we have the boom or not if we know that you need it and you're going to use it in these ways and it will be stored out of the way? Yeah, we're fine too. So at the end of this half-hour meeting, we had landed on our decision that, you know what, the boom was going to stay. This is where it was going to be parked. And really, you know, again, I think it's just giving voice to people. Really understanding why they feel the way they do. One of my mentors and really my boss, one of the things she has really, I've really learned from her is if people are resisting, there's a reason why they're resisting, and understand why. So that is the other thing we've really tried to do in this project is, you know, everyone has a voice. We've created a safe environment for the most part for people to speak. So no one has to be intimidated by the surgeon at the table. Yes, he's bringing expertise, but you know what? So are you. So if you're bringing your perspective forward, you're the expert in this conversation. Let's have the conversation. So really, we've done a lot of work, around that. And the other thing we do is if we do reach a point where the team can't decide, is we have escalation processes in place. So we have a steering committee that is our next level up, where it is our surgeon and leadership for the program. And what we do is we put it in front of them and they provide perspective. And if we need them to decide, they'll decide. And if for some reason that can't be decided, what we do is we take it up to our executive steering committee, which is my vice president and our executive sponsor for surgery and our senior medical director. So we've built in structure that if we can't decide, we escalate. But honestly, I can't think of anything offhand where we've actually had to escalate and someone has had to decide for us. We've really, as a team, this is our work, we own it. So we've been able to solve our issues. And again, just really bringing, for me, from my perspective, just getting the expertise at the table, and similar to what we've done with Jonas and his team when we brought them in, leverage experts. None of us are experts in everything, so it's how we come together and leverage each other's expertise, which has really brought us to where we are.
That is excellent. Thank you. Kind of our final question, and Jonas, kind of tagging off what Shelley just talked about. You know, we all know that the most successful project is a project that has a true champion within the system. And clearly Shelley has been that champion. And I just was hoping that you could take 1 minute and just kind of share what that has meant for your team in conducting the research, and what that has done for this project as a whole. And then we'll kind of close it out.
Sure. Yeah, absolutely. Absolutely. Shelley was the champion. She's a really good project manager, and everything that she just said, I would just basically reiterate that entire process, that decision-making process to flatten the curve. Because what it meant for us was we had access to all of the right people to design the scenarios. We had access to the right people to decide what is the scope of the evaluation. We had Biomed was more extensively involved in this project than ever before. And so when we needed things to be changed between scenarios to allow the scenarios to enact better, they were present and they were involved. And so really what it meant was all of the correct players and really everyone was just at the table to provide all of the support that was needed, especially with us being remote and then arriving sort of the day before the scenario enactments, created a lot of uncertainty for me, not knowing what the mock-up's going to look like. Are all of the things going to be in place? Do I have a place to mount the cameras and all of that, like just the logistics? And so to have someone really champion that whole project management and that engagement of the right players to get everything to be in place to have this all happen, I think was really helpful and made this really successful. Mm-hmm.
Thanks, Jonas. I'll just add one last comment as well. I think the other thing we did is we were very clear that not everyone was a decision maker. Really clear, when are you informing, when are you being consulted, when are you the decision maker? So we really worked on that from the beginning too, so that really manage expectations, right? So you're brought in, we're asking your opinion, but you're not a decision maker. So we were very clear on that structure as well, which made a difference. And it really is just, I think, clarity, role responsibility, and managing expectations so people know what their role is and what's expected of them.
Excellent advice. I thank you so much, Shelley and Jonas, for sharing your insights, your amazing work. It has just been phenomenal to spend this time with you. We really do appreciate it. We just wanted to say thank you again to Health Environment's Research and Design Journal for providing free access to the articles we discuss. I highly recommend that you all who are on the line go get this article if you've not already and read it. It is truly a treat. And be sure to subscribe to the journal using code HERD20 for 20% off. Once again, thank you to Pat Kraft for sponsoring today's EBD Journal Club. Please be sure to check the events page on the center's website to see a list of upcoming events. We have 3 behavioral health virtual workshops in May, so those will be excellent. And thank you again very much, Jonas and Shelley, for sharing your research study. This concludes our event. We will leave the webinar open for another 15 minutes, so you can download the EDAC and AIA CEU forms from the chat box or typing the tiny URL into your browser. Thank you again for joining us, and have a wonderful rest of your day.
Thank you, everyone.
Thank you. Thank you.